This conference will now be recorded.
Hello everyone. Today we'll discuss the general pathology, which is very important in exam for MRCOG part 1. So first we'll discuss about the cell injuries and the cell death, and after that we'll discuss the inflammation, and after that we'll discuss the adaptive change, and finally we'll discuss the Metaplasia. Okay, first we'll start with the cell injury and death. What is mean by cell injury and cell death? Cells are generally able to cope with the range of normal physiological demand, state referred to as homeostasis. So when there is fluctuation in the environment around the cell are more severe, leading to cellular stress. A number of adaptive response may occur. So if this, as we Virchow said, Virchow points out that all the disturbance of the function of the structure in the disease due to cell abnormalities. So if there's any cell abnormalities, this is can lead to disease. So the causes factor of the cell injury are ultimately the causes of acquired disease. So this is the cell function here is very important. So we should point out that all disturbance of the function and structure in the disease due to cellular abnormalities. So we'll discuss here any cell abnormalities and what is the cause of the cell injury, and finally cell death. So there are some adaptive response are characterized by the change in cell size and number. So if the cell have injuries, they have many adaptive change occur in the cell to respond to this stimuli. First is the hypertrophy. Hypertrophy, we'll discuss this later. Hypertrophy means there is increase in cell size. Respond to a stimulus. So if there's any stimulus can lead to hypertrophy. So this is increase in cell size. If a cell is increased in numbers, this is called hyperplasia. So the difference between hypertrophy and hyperplasia, in hypertrophy, there is increase in cell size in response to the stimulus. And hyperplasia, it is increase in number of the cells respond to the stimulus. So this is the difference. So this is maybe question in exam. What does mean by atrophy? So atrophy is decrease in the size of number of cells respond to the stimulus. So this is decrease in the size, atrophy. So if increase in size, this is the hypertrophy. And increase in number of the cell, this is the hyperplasia. And if metaplasia, what does mean by metaplasia? Anybody knows what mean by metaplasia?
So from one differentiated cell to another differentiated cell, the
Yes,
change.
change to another type.
Differentiated.
So mean by,
yeah.
yes. So this is mean by metaplasia. So it's adapt to changing their differentiation. So this is the metaplasia. We'll discuss in details later, inshallah. So this is about the response to cells to the injuries. We have three subgroups. If the just altered function demand, if there's any only functional demand, the cell may be have adaptive change to respond to stimuli, like atrophy, which is the decrease in size, hypertrophy, increase in size, hyperplasia is the increase in numbers, metaplasia change to the another types situation, and dysplasia. So dysplasia also is the change in the size and in the number and in the shape. So this is about adaptive change. So if the stress is removed or the stimuli is removed, so will return to a normal cell function. So this is about type 1. If mild to moderate stress, there may be reversible cell injuries. So can occur degenerations or subcellular alteration or intracellular accumulation. If the cell stress is removed, can repair and healing. And the type 3 is severe persistent stress. If there's still persistent or there's severe stress, so this may be irreversible cell injuries. So here we can lead to tissue necrosis and finally the cell death. So this is about fate of the normal cell respond to stimuli, either altered functional demand or mild to moderate stress or severe persistent stress. So the fate is depend on the type of the three. So what about the causes of cell injury? This is very important. Maybe it came in the question in exam. There is many causes of cell injuries. It is hypoxia. There is maybe hypoxia. What does it mean by hypoxia? It is mean there is deficiency of oxygen or chemical agent poisons or infectious agent, immune-mediated process, genetic abnormalities, nutritional abnormalities, and physical agent. So here in hypoxia, for example, there is deficiency of blood supply, so it is due to ischemia. And the chemical agent and poison, this is maybe to the adverse of medication and infectious agent like viral infection. This immune, this may be anaphylaxis reaction. The genetics may be chromosomal abnormalities and nutritional imbalance. So nutrition balance may be in the malnutrition or obesity, and physical agents may be due to low temperature or high temperature. So we have table here. We'll discuss about the cause of cell injuries. This is very important. Here we said first hypoxia. Hypoxia, this is the most important causes of cell injuries. So we'll discuss later in what is meant by hypoxic cell injuries. So the example for hypoxia is ischemia. So it is blood supply, poor blood supply. So lead to decrease the oxygen carrying saturation. And the chemical agents here as a salt or adverse of the medication or poison. This is about cell injuries due to chemicals, agent, or poison. What about the infectious agent? Maybe mainly is viral infection. Immune-mediated process, so it is respond to foreign bodies like anaphylaxis. So, or if there is any breakdown of normal tolerance mechanism of to cell antigen, so this is autoimmune disease. Genetic abnormalities, so it is, for example, there is chromosomal abnormalities like single base mutation. And nutritional imbalance, so in developing countries like malnutrition, kwashiorkor, and in developed countries, obesity and associated metabolic disorder. So this is about the nutritional imbalance. Physical agent, it is temperature. Temperature is very important as the cell causes of cell injuries. And atmospheric pressure, also radiation, direct radiation and indirect mechanical trauma and electrical current. This is about the cause of cell injury, because if the cell injury may lead to the cell abnormalities, may lead to disease. So that is why we discuss the causes of the cell abnormality. Here we'll discuss the hypoxia, the most important causes of cell injuries. So hypoxia or deficiency of estrogen, the most common causes of clinical practice is hypoxia, where the cell is damaged because of aerobic respiration is diminished. It can occur, there is reduction in the blood supply to the tissues, as occur in myocardial infarction. This is important. This is the important example for the hypoxia or the cell injuries due to hypoxia may occur in the myocardial infarction. This is maybe the question exam. We ask you about what is you give you a scenario about the patient have deficiency of oxygen and have cell injuries, and what is the example for the hypoxia. We give me any option, so you choose the myocardial infarction. This is the best example for the hypoxia or deficiency of oxygen lead to cell injuries. So such as impairment of blood supply, it is called ischemia. We said example is ischemia. So ischemia can lead to myocardial infarction. So this is about two stages of cell injuries, hypoxic cell injuries. So we said this is from the ischemia. So first we'll start with the ischemia, and maybe due to anemia, carbon dioxide poisoning, and poor perfusion of oxygen carrying blood. This is about the causes of hypoxic cell injuries. So in the early stage of hypoxic cell injuries, the hypoxic cell injuries first affect the mitochondria. It is affect mitochondria, so lead to decreased ATP. So decrease the ATP availability. So the hypoxic can occur due to ischemia, due to carbon dioxide poisoning, and so on. This hypoxia can lead to first affect the mitochondria, so decrease the ATP availability. So this is lead to cell membrane or failure of cell membrane. Thus, occurs failure of cell membrane pump. So this failure of membrane damage. So we failure of cell membrane pump. So after that, result in membrane damage to plasma. So membrane damage to plasma. Membrane damage to plasma, and finally to cell death. So this is about event occur due to hypoxia. First, if there's any causes for hypoxia like ischemia, anemia, carbon dioxide, and poor perfusion of oxygen carrying blood, this is a first in early affect the mitochondria, lead to decreased ATP availability, which lead to failure of cell membrane pump. In late stage, the hypoxic cell injuries result in membrane damage to plasma. So this is causes, if becomes severe or prolonged injury, may lead to finally cell death. This is about mechanism of cell death in case of hypoxia. Is it clear?
Yes, sir. Yes, sir.
Thank you. What about the chemical agents? Here we said chemical agents about salt and the medication or poisons. So There's many chemical agents can cause cell injury. Even some apparently innocuous substance, for example, salt, and in certain situation and concentration may bring about cell death. What about the other agents? It is include adverse effect of prescribed medication, poison, arsenics, and environmental pollutants, and reactionary drugs such as alcohol. This is about the other causes of the cell injuries. What about immunological reaction? This is anaphylaxis. So are also cause of cell injuries when there is exaggerated response to foreign proteins, anaphylaxis reaction, or there is breakdown of the normal tolerance mechanism to self-antigen autoimmune disease. This is about immunological reaction. What about the nutritional? We said before is kwashiorkor or the obesity or the associated metabolic syndrome. So nutritional imbalance can also cross such as that seen in protein calories. Malnutrition is kwashiorkor, and obesity and associated metabolic syndrome are major causes of serious disease, particularly in Western countries. What about the physical agents? Include temperature and atmospheric pressure, radiation, direct and indirect mechanical trauma, and electrical current. So we'll discuss about the cell death. I said we in hypoxia, we have two stages, and finally maybe we'll end with cell death. First is affect mitochondria and then can affect the membrane, cell membrane. So what about mean by cell death? This means loss of cell variability. So this is the simple definition of cell death. Can occur through two major and distinct best way, either necrosis and apoptosis. So this is very important here. In cell death, you should know about what mean by necrosis and what mean by apoptosis. So necrosis is a form of cell death that generally follows a sequence of events described above, culminating ultimately in loss of membrane integrity, where apoptosis is more tightly regulated pathway, often described as programmed cell death. So this is the most important difference. We'll discuss the difference between both apoptosis and necrosis, but generally here, the necrosis is the loss of membrane integrity, and apoptosis here is the programmed cell death. So the cell death without any inflammatory process. So this is the difference between the necrosis and the apoptosis. I'll discuss it later. In necrosis, there is many types of necrosis. So apoptosis may be physiological phenomena. So we'll discuss here the necrosis and the difference between necrosis and apoptosis. So what is the type of necrosis? And first with definition of the necrosis. So necrosis is the death of cell with loss of membrane integrity and enzymatic destruction of the cellular content constituted. This is the difference of the necrosis. So simple definition is the loss of membrane integrity. This is lead to leakage of cell constituents into the surrounding tissues and the circulation. So here there is inflammatory response. This is the difference between the necrosis and the apoptosis. Here there is inflammatory response to the cellular constituents and initiation of a repair process. So there's many types. There's different types of necrosis. So here we'll discuss the type of necrosis. What is meant by coagulative necrosis? So this is the typically seen in hypoxic in case of low oxygen. This is typically occur in hypoxic in low oxygen environment, such as infarction. So the mechanism here most often result from interruption of blood supply. So this ischemia, so lead to hypoxia, resulting in denaturation of proteins, the best seen in organs supplied by end arterioles with limited collateral circulation, such as heart and kidney. What is the pathological change? The external architecture well preserved except for nuclear change. So here the only occurs the nuclear change, increased cytoplasmic binding of acidophilic ties. So this is about pathological change. Liquefactive necrosis. So this is usually associated with cellular destruction and pus formation. So this is usually with the cellular destruction and pus formation. For example, here in case of pneumonia or in the brain infarction. So mechanism is enzymatic liquefaction of necrotic tissues, most often in the CNS. So it is in the brain infarction or cerebral infarction, where it's caused by interruption of blood supply, also occur in area of bacterial infection, pneumonia. So here the pathological change here in necrotic tissue soft and liquefied. This is about the liquefactive necrosis. So this is in cellular destruction and pus formation. What about the caseous necrosis? This is the specific form of coagulation necrosis, typically caused by mycobacteria in case of tuberculosis. So this is a specific form of coagulation necrosis. So the mechanism is the shared feature of both coagulation and liquefaction necrosis, most commonly seen in tuberculosis granulomas. And here there is pathological change. Here these architectures not preserved, but tissues not liquefied. And the cross appearance is soft and cheese-like. Histologic appearance is amorphous with increased affinity for acidophilic dyes. The others is the gangrenous necrosis, which occur maybe in the clostridial infection. Here most often result from interruption of the blood supply to a lower extremity or the bowel. Change depends on the tissues involved and whether gangrene is dry or wet. Fibrinoids necrosis. This is the immune reaction in vessels. So mechanism is characterized by the position of fibrin-like proteins, and in the pathological change, here there is a pink appearance in vascular wall. Actual necrosis may not or may not be present. What about finally the fat necrosis? This is maybe result from the action of lipases on fatty tissues. Example, acute pancreatitis, the breast tissues necrosis. This is the action of the lipases on fatty tissues. So mechanism here, lipation of the pancreatic enzymes, lipases, with auto distinction of pancreatic parenchyma trauma to the fat cells. So here in the pathological change, the necrotic fat cell with acute inflammation, hemorrhage, calcium salt formation, and clustering of lipid-laden macrophage. This is about the type of necrosis. Here, this is the example. Maybe came the exam question, ask about, you give you type of necrosis and ask about the example for the necrosis. In coagulative necrosis, for the best example is the myocardial infarction. The coagulative or the liquefactive necrosis, the example is the the necrosis occur in the cerebral as a cerebral infarction. Cases necrosis here, tuberculosis, lymphadenitis, gangrenous necrosis in the clostridial infection, and fat necrosis in case of acute appendicitis. This is picture show the about common form of necrosis. Renal infarction is A. This is a renal infarction, well divided area, and the B is the cerebral infarction. This is about the type of the necrosis. So what is meant by apoptosis? Apoptosis is programmed cell death in which the cell initiates a genetic cell death program via characteristic or intrinsic pathway in increase to a range of the stimuli. So it is the programmed cell death. It is lead to deletion of the individual cell. So it is lead to deletion of the individual cell. The membrane remaining intact with engulfment and destruction of the cellular remain by adjacent cell or macrophage. The inflammatory response is not generally seen in apoptosis. This is the important difference between the necrosis and the apoptosis. Here, the inflammatory response is not generally seen in apoptosis. The cell undergo shrinking and with condensation and fragmentation of the nuclear chromatin. So here the changes occur in the nuclear, so lead to shrinking and condensation or fragmentation of the nuclear chromatin. So apoptosis may occur under physiological circumstances, so some form of the radiation injuries, and maybe elimination of tumor cell, or maybe elimination of cell infected with virus, or in case of neurodegenerative condition. Here, there is comparison between necrosis and apoptosis. First, we'll start with pathology. Here, this gross irreversible cell injuries. Here, apoptosis is subtle cellular damage, physiological programmed cell removal. Morphological change. Here, involve many contiguous cells, and there is increase in cytoplasmic eosinophil due to denaturation of the protein. And there is also progressive nuclear condensation and fragmentation with eventual disappearance of the nuclei and preservation of tissues architecture in early stage of coagulative necrosis. Here in apoptosis, it is involved single cell or cell cluster of cells, and the cytoplasmic shrinking and increase in eosinophilic staining. Biochemical change, here is the passive form of cell death. And apoptosis, here is the active form of cell death, so require gene expression, protein synthesis, and energy consumption. Inflammatory reaction, here is the marker, there is inflammatory reaction, and in apoptosis, there is no inflammatory reaction. Now we'll discuss the inflammation. So what does mean by inflammation? Inflammation, it is the local response of living tissues to the injury from any agent, which may be microbial, immunological, chemical, and physical agents such as trauma, radiation, heat, and cold. So this is mean by inflammation. On the other hand, inflammation and repair are the local response initiated to the limit the damage caused by tissues injuries, infection, toxin, and ischemia, and to aid recovery from tissues damage. So the inflammatory response is divided into acute and chronic inflammation. Here in this picture show the acute inflammation and chronic inflammation. So if there's any stimuli, if there's any injuries, maybe infarction, hypoxia, or infection, or the chemical toxin, or the trauma. So if there's any injuries, can lead to cell injuries or initiate the inflammation. So inflammation is the response to any agent. So will lead to acute infection. So the acute infection is characterized by vascular change. What is the vascular change here? First, we'll start with the transient constriction, and then the vasodilatation. So this vasodilatation can occur, and neutrophils recruitment. So this is the neutrophils, and this exudate is occur, and the protein here so limited, and there is limited tissues injury. So this is about the acute inflammation. So white blood cells here, and then occur of edema, and this protein exudate. So this is the acute inflammation. So the fate of the acute inflammation depends on the stimuli, or depend on the injuries. If acute inflammation and the healings occur, maybe end with resolution. So resolution, what does mean by resolution? What does mean by resolution?
Revert back to normal.
Yes, excellent. It is return to normal function. So the cells return to normally and to do the normal function. So this is about resolution. It is occur this clearance of injurious stimuli in phagocytosis, and the clearance of mediator and acute inflammatory cells, and replacement of injury cell, and finally return to the normal function. So this is the normally cells. So this is if this resolution is occurred. So in case of there is progression, if the stimuli is persistent, or the stimuli is more potent than inflammatory response. So if the stimuli is persistent, or there is maybe lead to progression, may lead to chronic infection. Maybe chronic infection can occur directly. There is many causes of direct of the chronic inflammation, like viral infection, chronic infection, persistent injury, and autoimmune disease. This is maybe lead directly to the chronic infection, which is maybe angiogenesis and mononuclear cell infiltrate, and fibrosis, these scars and progressive tissue injury. If the acute inflammation have the inflammatory response more than inflammatory cells, this can lead to fibrin production. So this is here is the healing, can lead to fibrin production, and finally the cause is the chronic inflammation with fibrosis. If here the stimuli here is the more potent than inflammatory cell, may lead to pus formation. So here this is about the fate of acute inflammation. Is it clear?
Yes, sir.
So what is the acute inflammation? Acute inflammation is the initial response to the tissue injury in most circumstances, and the main causes are bacterial infection, hypersensitivity reaction, and physical agents such as radiation, chemical reagents, including toxin, tissue necrosis following infarction. What about the response to tissue injuries? The initial response to tissue injuries, there is the vascular phase of increased flow, exudate formation, neutrophils, polymorphs, and in the bacterial phagocytosis and killing and dissolution, separation and organization and chronicity. So what about the vascular phase of increased flow? The vascular event, it is alteration in the microvasculars, so in the arterioles and capillaries and venules. So it is respond to the injuries and lead to transient vasoconstriction. So first we'll start with the transient vasoconstriction and follow it immediately by progressive vasodilatation, which lead to increased hydrostatic pressure and transudation into extravascular space. So this is about vascular phase. So it is first respond to the injuries, lead to transient vasoconstriction, and rapidly followed by the progressive vasodilatation, which lead to raised hydrostatic pressure. So lead to transudation into extravascular space. Exudate formation, how the exudate is occurred. Here, this is the crucial factor in formation of inflammatory exudate is the increase the permeability of the vessels wall to the plasma protein. So if the vessel walls increase to the plasma protein, this is lead to exudate. So what is the difference between exudate and transudate? What is the difference? Regarding the protein, regarding the cell, is there any difference?
Yeah, proteins are high in exudate, whereas transudate it will be less.
Yes, excellent. In exudate, there is high protein, maybe contain more than 25 grams per liters protein. So, and transudate have low protein concentration, and the exudate contain more cells. So this is the difference between the transudate and exudate. And neutrophil polymorph infiltration tissues and bacterial phagocytosis and resolution of separation and organization or crisis. This is about initial response to tissue injury. What is the type of inflammatory cells? First is the neutrophils as the most prominent inflammatory cells in foci of acute inflammation during the first 24 hours. So inflammatory cell is very important to know the role of every inflammatory cell, because maybe came in exam as question is neutrophils, what is the neutrophil, and it's appear in the first 24 hours. What the important cause of neutrophilia, increased neutrophils in the peripheral blood, include bacterial infection and other causes of acute inflammation. The release of the early release of neutrophils into peripheral blood in acute inflammation is the form of bone marrow post-mitotics reverse bull. This is often increased in the proportion of the less mature cells such as pan neutrophil. So this is neutrophil is the most prominent inflammatory cells is occur in the first 24 hours. After 2 to 3 days, neutrophils are replaced mainly by monocytes, macrophages, which are capable of engulfing large particles are long-lived, which form the epithelioid cells. This is the accumulation of the macrophage. And lymphocytes are the most prominent inflammatory cell in many viral infections. So if you give example, you give you scenario about the viral infection and ask about the important cells. So the most important inflammatory cell here is the lymphocytes. Eosinophils also is the predominant inflammatory cell in allergic reaction. So in allergic reaction, the predominant cell is the eosinophil. And the mast cell and basophils are source of histamine. So this is the important mediators. Important causes of basophilia include chronic myelogenous leukemia. This is briefly about the inflammatory cell. So this chart show what is the progress of the acute inflammation. So if this any stimuli lead to injuries or the infection, like bacterial or viral or trauma or physical as temperature, radiation, and tissue necrosis, and immune reaction, hypersensitivity, and foreign bodies, so may lead to mast cells degenerate. So the mast cell degenerative lead to release of the histamine, leads to release important mediator. Here the histamine and serotonin. And this may lead to vasodilatation. So we said vascular change here, the important of first occur transient vasoconstriction and then followed by rapidly progress vasodilatation. So vasodilatation is very important because it increases the vessel calibry and so increase the blood flow and increase the permeability, so lead to transudate. So lead to transudate. And this vasodilatation can lead to redness and hotness. This is the cardinal sign of the inflammation. So after transudate, the fluid to this interstitial space, so can lead to leakage of the plasma protein. So this is exudate. So protein is leakage of plasma proteins and may lead also there is increase in vessels. This is vessels permeability also can lead to the leakage of protein. So there is migration of addition of leukocytes lead to transmigration, and this leukocyte activation and termination here. The final is the mediator breakdown or removal of the stimuli or anti-inflammatory mediator. Here is also may lead to chemical mediators. Here can lead to exogenous and endogenous, and lead to migration of chemotaxis. And endothelial cells also here can lead to nitric oxide, also lead to vasodilation, then increase vesical pre and flow, and leads to the transudate leakage of fluid in the interstitial space, and lead to leakage of the plasma protein transudate. This is about the flow charge of the acute inflammation. So what about the cardinal sign of inflammation? So the cardinal sign of inflammation are redness and heat. So we here, look here, we said there is increase in visual calipari and flow lead to the redness and hot and the heat. So this is the cardinal sign of inflammation and red and heat, and this may be edema lead to swelling, and if there is any pressure on the peripheral nerve injuries, so, peripheral nerve may lead to pain, and maybe all of this lead to finally loss of function. So this is about the cardinal sign of inflammation. Here, if there is vascular change, may lead to vasodilation. So this is about the response to the acute inflammation first with the vascular change. First, this first will start transient vasoconstriction, then vasodilation. This is lead to vascular change. And here is the, if there's vascular change, vasodilation, increase visual calipari and flow lead to increased capillary permeability. So lead to leakage of plasma protein. So this exudation, maybe there is swelling, and this is may lead to swelling, and it may be there is pressure on the local nerve injuries. This is may lead to pain, and finally the impairment of the function. This is about the cardinal sign of the function, which occurs swelling and the pain and the impairment of function. So what about the chemical mediator of inflammation? So inflammation, there is important chemical mediator. Either cell-derived mediator or the plasma protein-derived mediator. So the cell-derived mediator is the vasoactive amines. So this is histamine, 5-hydroxytriamines, and neutropeptides. So what is meant by vasoactive amines? This is the early feature of acute inflammation and the release of histamine and heparin due to degeneration of the mast cells in the adjacent tissues. So additionally, many chemical substances may involve in the process of acute inflammation. So this is lead to vasoactive amine are responsible for producing early vascular change. So the histamine is the mediator which is released by mast cell, and the vasoactive amine, it is responsible for producing early vascular change, and the metabolized via cyclooxygenase pathway, the metabolized in lipoxygenase pathway and platelet activating factor. And the plasma protein derived mediators is the product of kinase system. Kinase system, for example, is the bradykinin, which is cause smooth muscle contraction. And the fibrinolytic system and complement system. So the components of the complement system may act as chemotatic agent, so attracting the white blood cell to the bacteria. So this is the function of the complement system, is to attracting the white cells to bacteria. Here about the mediators of acute inflammation, either cell type or plasma protein type. So the mast cell, you said, basophils and platelet, so the mediator can release the histamine, so increase permeability. So increased permeability may lead to exudation. Platelets, serotonin, also main function is increase permeability, and inflammatory cells. Here is the prostaglandin. Here the main function is the vasodilation. Leukotrienes here also increase permeability, and lysosomal enzymes here is the main function tissue damage, and platelet activating factor increase the permeability. Cytokines lead to fever, and nitric oxide and oxygen metabolize cause tissue damage. And the plasma protein private floating and fibrinolytic system is a split mediator, and this mediator increase the permeability, and the system either bradykinin. The main function of the permeability.
Mr. Shah, there is a mic which is on, Dr. D. Mute.
Hello?
Mic is on, Dr. D, which is, yeah, thank you. Thank you.
Okay, welcome. So what is the effect of the acute inflammation or degree of the acute inflammation? Either resolution, abscess formation, or healing by fibrosis, scar formation, and or the chronic inflammation, and discussed before. So this is about tissues damage lead to acute inflammation, either causative agent removed. So if no tissues lost, the resolution is will occur. And this separation, if the tissues loss, may lead to repair or the regeneration or the clone. If there's chronic inflammation of the causative agent persist, and this is finally end with fibroids. So what is the chronic inflammation? The chronic inflammation may result either following acute inflammation, may start anew after recurrent attack of acute inflammation, or may start de novo infection with organism of low pathogenicity. Example, infection with Mycobacterium tuberculosis. So it is slow and gradual in onset and persistent for weeks or months after the initial injuries. So what about the general feature of the chronic inflammation? So a few general features of the chronic inflammation are the infiltration of the mononuclear cells and tissues destruction and proliferation of blood vessels and fibrolysis. This is about the general feature of the chronic inflammation is the infiltration of the mononuclear cell and tissue destruction and proliferation of the blood vessel and fibrolysis. So this is table shows the difference between the acute inflammation and chronic inflammation. So in definition, it's a short time. and this is may after delay last longer. Here lasts for short duration. My voice clear? Hello?
Yes, Dr. Fahd.
Okay. Here, and the cardinal sign here presents and generally indiscernibles. And what about the pathogenesis? Here, this acute inflammatory process is initiated as a result of vascular and cellular event. So we'll start with vascular event like hypodynamic change, increased vascular permeability, lead to exudate and transudate and then exudate. And the chronic inflammatory process following acute inflammation and recurrent attack of acute inflammation and chronic inflammation from the beginning. What about the main inflammatory cell involved? This is important. Here is the neutrophils, eosinophils, and lymph mononuclear cells in late stage, and the pus cell. Here, the lymphocytes, this is the granulation tissue formation we'll discuss later, and plasma cells, and monocyte and macrophage, and Cain cell. We'll discuss granuloma. Plasma exudate, here is present in acute inflammation, may or not be present in chronic inflammation. Systemic effect here, fever is high-grade fever, leukocytosis, lymphadenitis, and septic shock. This is an acute infection. And here fever is mild, leukocytosis, and lymphadenitis, and raised ESR, may be anemia and amyloidosis. This is characteristic for the chronic inflammation. Morphology, here is abscess, ulcer, and here is chronic non-specific inflammation. And the characteristic is the granulomatous inflammation. This is characteristic to the chronic infection. What about the fat? The acute inflammation, this may induce resolution, no return to the normal function, or healing by regeneration and fibrosis, or the chronicity. Here also may be resolution or healing or dystrophic calcification. What about the example? For the acute infection is pyogenic abscess, cellulitis, and bacterial pneumonia and pyemia. And in chronic, there is granulation tissues and granulomatous inflammation in case of tuberculosis. So this is about the major difference between the acute inflammation and chronic inflammation. The chronic inflammation arises in three ways. Progression from acute inflammation, or recurrent episode of acute inflammation, or chronic infection. This is about the chronic inflammation or the three pathway of the chronic inflammation. So what is about the morphological feature of the chronic infection? The macrophage, they circulate in the blood as monocytes, which leave the circulation through the postcapillary venules and converted to the macrophage. In chronic inflammation, there is continuous recruitment of monocytes from the circulation. As the site of inflammation, macrophages become activated by cytokine interferon, and the activated macrophages are large and have increased phagocytic and bactericidal activity with increased content of lysosomal enzyme and avoids movement. Foreign bodies and certain encapsulated microorganisms, histoplasma, may survive in microbiota for long period, resulting in phenotypic change with formation of epithelioid cells and Guylian cells. So epithelioid cells, this is a collection of the macrophage, and Guylian cell also, this is a type of macrophage. Lymphocyte and the plasma cells for immune response. T lymphocyte secrete cytokine, which are chemotactic for the monocyte, which activate macrophage, and fibrinolysis, which are accompanied by capillary fibrosis. Neutrophils may be present if there is persistent separation of the chronic osteomyelitis or respond to certain infection, and finally the eosinophils are found in parasitic infection. This is the characteristic of the chronic infection. Here is the chronic granulomatous inflammation, or the formation of the granuloma. This is important in chronic infection. So the granuloma here, the formation of the granuloma is the type 4 hypersensitivity. It is the type 4 hypersensitivity action. So it is the protective defense reaction by the host. So how the granuloma is composed? So the granuloma is composed of modified macrophage known as epithelioid cells. So we'll discuss how the granuloma cell formation. So it's composed of the first is the epithelioid cells. Here, number of macrophage. This is the epithelioid cells. After that, this form of the Guylian cells contain a lot of nuclei. It is the multinucleated Guylian cells. It is termed Langhans. It is the multinucleated Guylian cells. So this is the multinucleated Guylian cells. And then attack the lymphocytes. So it is the lymphocyte. There is the mainly lymphocyte. The mainly is T cell lymphocyte. Here, important to produce the cytokines. Here, this is the lymphocyte. Here in the middle. The lymphocyte here, mainly T cell. This is the lymphocyte in the middle layer of the granuloma, and in the outer layer is predominantly the fibroblast. So here fibroblast, it is the outer layer. So this is a fibroblast. So this is about the formation of granulomatous. So first with the epithelioid cells and multinucleated Guylian cells, and surrounded by the lymphocyte, mainly T cells, which produce the cytokine, and the outer layers is by fibroblast, which will produce collagen. So this is about the formation of the macrogranuloma. So the inner layers is mainly composed of the epithelioid cell and multinucleated ganglion cell. And the middle layers is the lymphocyte, mainly T lymphocyte, and the outer layers is by predominantly fibroblasts, which produce the collagen. So what the wound healing? So we'll discuss the wound healing. Here, the healing is the body response to injury in attempt to restore normal structure and function. So we mainly wound healing either regeneration or fibrosis. So there is compromise of two processes: regeneration and repair. So it is consists of two processes: regeneration and repair, or fibrosis or scar tissue. So what mean by regeneration? So it is healing by the same type of tissue cell from surrounding healthy living cells. This is occur in the small damage of labeled cells and stable cells. You know the classification of the cells according to the mitotic ability. What is the classification cell of the cell according to mitotic ability? Anybody knows? Here we have permanent cells and stable cells and label cells. So here regarding the mitotic ability. So the first is the permanent cell is that cannot be divided. So cannot be divided. And the stable cell have ability to regenerate or to divide if the stimuli if occur. This is in, for example, in liver cells and labels cells. This is the have characteristics of continuous regeneration. For example, the gastrointestinal mucosa, so regenerated and have ability to continuous regeneration. So this is about the three difference between the permanent cells and stable cell and label cells. So here in the regeneration is occur in the label and stable cells. And the fibrosis or the scar tissues or the repair, this is healing by granuloma tissues with mature avascular fibrosis tissues. This is occur is the healing process of the permanent cell and stable cells with high damage. So regeneration, this occur with the small damage of label cell and stable cell. And repair or this fibrosis, this occur in health healing process of permanent cells and stable cell with high damage. So this is different between wound healing. Wound healing can be accomplished in one of the following two ways. What is the type of wound healing? Can occur through the healing by first intention or healing by second intention. Here also about the classification of wound. Is a clean wound. Here is if there is no inflammation and in gastrointestinal or genitourinary tracts are not entered, the risk of infection is about less than 5%. And clean or contaminated, this is in respiratory or genitourinary tracts are entered, and the risk of the infection is 5 to 10%. And contaminated wound, here is this acute inflammation, and there is visible contamination of the wound, and the risk of infection is about 10 to 20%. And the dirty wound here is presence of pus, and the risk of infection is about 30%. This is about classification of wound. So we'll discuss the healing by the first intention. Healing by first intention can occur in a wound which is clean and unaffected, created after surgical incision and or associated with the minimum loss of cell and tissues. It includes the cases where the edge of the wound are approximately by surgical suture. In case where the wound edge are post, healing proceeds rapidly to closure. This is known as the primary healing. Here, this is the picture show healing by primary and healing by secondary intention. So this is the first picture show the wound edge joined by fibrin pulp. Here, the fibrin is pulp here, and the blood clot and tuberous fills the small cleft, and early inflammation close to the edge and macrophage activity remain clot. So this is lead to wound edge joint. So regrowth of the basal layers of epidermis, and then lysis of fibrin and re-epithelialization, and finally restoration to the intact skin. Healing by secondary intention, there is large defect filled by fibrin clot. Here there is large defect and granulation tissues. Here occur this formation of granuloma. New blood vessels and fibroblastic granulation tissues grow from the dermis into fibrin. Here the fibroblast produce the collagen, and finally maturation of the collagen achieve structural integrity and allow regrowth of epidermis. So this is about healing by secondary intention. Healing by secondary intention occur in open wound. So this is the difference between the secondary intention and the primary intention. So the healing by secondary intention occur in open wounds, have a large tissue defect. So there is a small defect in primary intention. Having a large tissue defect which what at time may even be infected. And this is one may be associated with the extensive loss of cell and tissues. Such wounds as approximated by surgical tissues suture but are not left open. Healing by second intention often result in formation of a large and times ugly scars. So what is the factor influence wound healing? Look, there is local factor and systemic factor. So here, the local factor is the infection. So the infection here is important. The most important factor acting locally, so which delays the process of healing. So an infection can lead to delay of healing. And vascularity, also this important factors. If there's any poor blood supply to the wound, this can lead to delay of the healing process. And movement also can lead to delay, so it delays the process of wound healing and respond to stretching and keloid formation. What about the foreign bodies? Foreign bodies include also the suture, which interferes with the healing and cause intense inflammatory reaction and infection. And also the exposure to ionizing radiation. This may lead to delay the formation of granuloma tissues. And exposure to ultraviolet light, this is maybe facilitate the healing process. Maybe facilitate the healing process. And type and size and location of injuries, yeah, this is important because this help in determine whether healing take place by resolution or organization. Necrosis, yes, necrosis. The presence of necrosis in the as the tissue's margin delays the repair of process. So if there's any necrosis, this may lead to delay the repair process. Lymph drainage, so lymph drainage also can cause edema and delay in repair process, and also amount of tissues separation of zone. This is about the local causes of which affect our influence in the wound healing. So what about the systemic factor about the age? So wound healing occur rapidly in young people. So systemic factor is important, the age. So wound healing occur rapidly in young people. What about the nutrition? How to influence the wound healing? So deficiency of constituents like proteins, vitamin C, vitamin A, and zinc delays the wound healing. So also deficiency of vitamin C lead to failure of collagen formation. So this is why the nutrition can affect the wound healing. And systemic infection, also systemic infection usually delay wound healing. Administration of glucocorticoids, and this is also delay wound healing. What about the diabetic patient? If there's uncontrolled diabetic are more prone to develop infection and hence delay in healing. Hematological abnormalities. If there's any presence of the hematological abnormalities such as defect of neutrophils function, and this is may lead to decreased chemostasis or loss of phagocytosis or neutropenia. So this is may lead to slow the process of wound healing. And temperature also, wound healing usually occur slow at low temperature. So this is about systemic effect in wound healing. So now we'll discuss the adaptive change. Here, what is meant by atrophy? Atrophy, can be described a reduction of number and size of parenchymal cells of organs which once normal. So atrophy, it is the reduction in number and size of the parenchymal cell. Hyperplasia, it is increase in number, the number of the parenchymal cells, and hyperplasia also due to physiological causes. It can occur, for example, is hyperplasia of uterine smooth muscle during pregnancy and hyperplasia of breast tissues during puberty. So if you give the question in exam asking about the adaptive change occur in the uterus or the small muscle during pregnancy, uterine small muscle during pregnancy, so this is you choose hyperplasia. In some cases, hyperplasia can occur to pathological causes. In hyperplasia of the adrenal cortex, in case of Cushing syndrome, and endometrial hyperplasia respond to unopposed estrogen. Hypertrophy, it is increase in size. Hypertrophy is increase in size. And metaplasia, metaplasia is a pathological change which refers to reversible replacement of one type of differentiated cell with another type of mature differentiated cell. So this is different between metaplasia. So metaplasia can be physiological and can be pathological. Metaplasia can be physiological in, for example, in squamous metaplasia in uterine cervix respond to change in pH of the vagina. This is the physiological. And pathological in smoker, so the pseudo transfied respiratory to stratified squamous. So this is in case of pathological in the smoker. And dysplasia, in dysplasia there is abnormal maturation of cells in the tissues. So there is change in shape and the arrangement and the number and the nucleus. So lead to abnormal cell and finally end with loss of function. This is about dysplasia. And heteroplasia and neoplasia. And neoplasia is uncontrolled disorderly proliferation of cells resulting in a benign or malignant growth known as neoplasm. What about the histogenesis of the tumors? So tumors are further classified according to the cell type that they resemble, so their differentiation. It is maybe epithelial tumor and connective tissues tumors and germ cell tumor and the tumor of necroderm. This is about the 4 types of the tumors. So epithelial tumors, for example, is the benign epithelial tumor is the papilloma, for example, and the adenomas and the adenocarcinoma and the transitional cell carcinoma and small cell carcinoma. And the connective tissues trauma, also this is the second types, and germ cell tumor, and finally tumor of necroderm. This is about the histopathology of the tumors. Here, this table shows the difference between the benign and malignant. In epithelium, these benign tumors is adenoma and papilloma, and malignant is adenocarcinoma and papillary cancer and blood vessels. This malignant, here leukemia and lymphoma. Blood vessels is the hemangioma and malignant is angiosarcoma. And blood vessels, smooth muscles, leiomyomas, is benign and malignant leiomyosarcoma, and skeletal muscle is benign is rhabdomyoma and rhabdomyosarcoma malignans. Connective tissues is fibroma and fibrosarcoma, and malignance is the fibrosarcoma. And bone is osteoma, benign, and osteosarcoma is malignant. How the tumor was spread, and the spread of malignant tumor can occur either local spread, lymphatic spread, hematogenous blood spread, translomic spread, and intraepithelial spread. So this is about 5 forms of the tumor spread. So local spread, the malignant cell have the ability to distribute themselves between the adjacent normal cell and invade the surrounding tissues. For epithelial tumor, the first step is the tumor cell to reach the basement membrane. So, example is the proceed from the stage of intraepithelial neoplasia to that of the invasive tumor. Is it at this point the cell of the tumor can said to have become malignant, and tumor cell follows the path of the least resistant and spread easily through the loose fibrous and adipose tissues, and dense fibrous tissues such as fascia and periosteum tend to form more of a barrier, but eventually are to penetrate. Also, there is lymphatic spleen, and this is the principal mode by which the carcinomas spread. So this is the lymphatic spread. So this is the malignant melanoma has spread extensively through the lymphatic. In the leg, this is the in the leg. This is the melanoma. Hematogenesis spread also. This is one of the way of the cancer spread. So this is large yellow renal carcinoma is seen invading the opening renal vein. The tumor can penetrate via the inferior vena cava and reach the heart. Transcolomic spread also, and this is a Paget disease of the nipples, resulting of eczema-like appearance of the overlying skins. So this is the eczema-like appearance. This is the Paget disease of the nipples. So difference between the benign and malignant tumor. So here the benign in boundaries is encapsulated or well circumscribed, and in malignance the boundaries is poorly circumscribed and irregular. The surrounding tissues in benign is often compressed and malignant usually invade, and the size in the benign usually small and often longer in malignance, and secondary change occur less commonly in benign and occur more commonly in malignant. And what about the growth rate? In the benign usually slow and malignant usually rapid. So this is characteristic of malignance. Local invasion here usually infiltrate and invade the adjacent tissues, and metastasis frequently present, so it's absent in benign. Prognosis is good here in benign and poor in malignant, and histopathological pairs usually resemble the tissues of the origin closely, and it is poor resemblance to the tissues of origin. And the nucleoplasmic ratio here is the normal, and here they increase the nucleoplasmic ratio. What about the mitosis? May be present here. Mitotic figures are increased and generate atypical and abnormal, so lead to dysplasia and so on. Function usually well maintained and may be retained, lost, or becomes abnormal. This is simply about the difference between benign and malignant tumor. What about the clinical feature of tumors? You have benign tumor and malignant tumor. So the benign tumor, the presence of palpable disease may be present of palpable lump, often painless, but occasionally causing discomfort. So the effect of substance produced by the tumor, so the cells of the benign tumor are well differentiated and often retain the function of the tissues of origin, such as production of hormone. This is usually out with the normal feedback mechanism, and overactivity may result. The thyroid adenoma may lead to hyperthyroidism. The effect of adjacent tissues due to pressure from expansion of the tumor. This is seen particularly when the tumor arises in a confined area, example within the cranial cavity. Malignant tumor is direct effect of the primary tumor. Here, the malignant tumor may cause palpable mass, which often grows rapidly and compress adjacent structures such as a nerve and result as pain. Despite the angiogenesis that is induced, malignant tumor often outgrow their blood supply so that there is central necrosis. Blood loss due to hemorrhage from the ulcerated carcinoma may be acute or chronic, thus leading to iron deficiency anemia. And carcinomas often causing narrowing, stenosis, or complete obstruction of the hollow vesicle. So this is about malignant or metastatic effect or non-metastatic effect. Here's a pathological diagnosis of tumor, either biopsies of the histopathological assessment, either excisional biopsy or needle biopsy. So excisional biopsy in this process usually performed for relatively small tumor. The entire lesion is removed and submitted for examination. And the excisional biopsy, in this process, the surgeon exposes the tumor and remove a wide wedge of the tissues, giving a fairly large and hopefully representative specimen. On the basis of the biopsy result, either immediately by the frozen section or after a day or so, the appropriate therapy can be instituted. A needle biopsy, many tumors, including deep seated ones under radiological control, can be sampled by needle biopsy. Here, this is a common immunocytochemical marker of valve in the cancer and commonly used tumor marker. Here about cytoproteins, and this means and fibrillary acid protein and alpha fetoproteins and human chorionic gonadotrophin, calcitonin, and cryoglobulin. And this is the commonly used tumor marker as the marker, the alpha fetoproteins in the tumor marker of the teratoma, hepatocellular carcinoma, and the human chorionic gonadotrophin is the tumor marker of the choriocarcinoma and teratoma, and prostate-specific antigen is the prostatic carcinoma. CA125 is the epithelial ovarian tumors, and embryonic antigens is the tumor marker of the carcinoma, example for gut tumor and lung tumor. Calcitonin is the medullary carcinoma of the thyroid, and thyroglobulin is the tumor marker of the follicular and papillary carcinoma of the thyroid. Carcinogenesis, what is the etiology of the tumor? These may be environmental factors, so there's many chemical have implicated in causing cancer in the human. This is about some chemical associated with the human cancer. Chemical here, chelating agents, carries chemotherapy and lead to leukemia, apoptosis, can lead to mesothelioma, and the others chemicals. And also the radiation can cause the tumor, and also there's viruses and cancers. And this is the virus implicated in human cancer. This is the virus papilloma virus, especially type 16 and type 18. So this is the can lead to cervical carcinoma, anal and penile carcinoma. Epstein-Barr virus can lead to nasopharyngeal carcinoma, Burkitt's lymphoma, and Hodgkin lymphoma, and hepatitis B and C virus, hepatocellular carcinoma. Human T lymphotropic virus can lead to T-cell leukemia, and herpes virus can lead to Kaposi sarcoma. And finally, genetic factor like familial cancer syndrome and familial cancer and autosomal recessive disorder to affecting DNA repair. So this is about all of the general pathology. So this is the question 1. Who will share? Question 1. Hello.
Hypertrophy.
Atrophy.
You can read the question, please.
The illustration shows a section of the heart from a 45-year-old African American man with long-standing hypertension who died of a stroke. Which of the following adaptive changes is exemplified in the illustration?
Yes. So what was the adaptive change here?
I think atrophy.
Sir, it's hypertrophy, sir.
Yeah. Agree with B?
B. Yeah.
Or D?
Option D.
D. It's
Hypertrophy.
Yeah.
Hypertrophy.
Look for the cell here. Is the increase in size. The hypertrophy. Yeah. Thank you, Dr. Maya.
Yeah. Thank you, sir.
Question 2.
Yes.
Yeah, please.
We roll.
Can you read the question? A 45-year-old woman is investigated for hypertension and is found to have enlargement of the left kidney. The right kidney is smaller than normal. And contrast studies revealed nodes of the right renal artery. The side change in the right kidney example in which the following adaptive change. So what is the answer? Yes, Dr. Monzi. It is. Is it B?
B.
B. Atrophy.
Yes, agree with atrophy.
B. Atrophy.
Yes, the answer is B. Yes. Thank you, Dr. Abina, Dr. Monzi, Dr. Maya. So the last question, please. We ask about the predominant inflammatory cells.
Sir, a 72-year-old man presents with 3-day history of progressively worsening productive cough, fever, chills, and signs of toxicity. Prominent physical findings include signs of consolidation with raised over the right lung base. Sputum culture is positive for Streptococcus pneumoniae, and intra-alveolar exudate filling the alveoli of the involved portion of the lung is present. Which of the following type of inflammatory cell is most likely a prominent feature of this exudate? It's D. Monocyte macrophages.
What is your
The
answer?
3-day history, है ना, because there is 3-day history of this productive cup. So after 3 days, the neutrophils will convert into monocyte. They will be replaced by monocyte macrophages.
What is your answer, Dr. Abina?
Yes, sir.
What is your answer?
D. Monocyte macrophages.
D or E?
E.
E.
is the bacterial infection, Streptococcus
Yes,
pneumoniae.
at first there is 3-day history of progressive worsening of structures, 3-day history. So after 3 days,
Activate here is the chronic infection. Mainly is the chronic infection. Yeah, the microbial is different. But here,
is
agree with
neutrophils.
E.
Neutrophil.
So the answer is E. Can you read the explanation here?
Explanation. The patient has bacterial pneumonia due to Streptococcus pneumoniae, a classic example of severe acute inflammation. In the early stages of acute inflammation, the neutrophil is the most prominent inflammatory cells. It is noteworthy that in many instances, bacterial infections are characterized by neutrophilic infiltrates. It is also noteworthy that Streptococcus pneumoniae, also known as pneumococcus, is the most common etiological basis of lobar pneumonia.
Yes. Thank you, Dr. Abinna. Thank you so much.
Thank you, sir.
Okay. Thank you. Thank you all.